Hello everybody, it's Simon Shaw from Sustain here. Welcome to our webinar this afternoon. I imagine we'll get a few people joining as we do these introductory talks, but I didn't want to keep you waiting. So welcome to this webinar hosted by Sustain, focusing on home from hospital and what happens when people are discharged from hospital in terms of their food access. So a really important topic, I think. For those who aren't aware, we've got quite a lot of people who I don't know, some new names, unfamiliar names on the attendee list, which is fantastic. But for those who don't know, Sustain's an alliance for better food and farming. We've got over 100 members from across the food and farming world, and together we advocate for food and agriculture policies and practices that enhance the health and welfare of people, animals, improve the working and living environment, and enrich society, culture, and promote equity. So as part of that work, we promote and champion support for older and disabled people around food, and we focused quite significantly on Meals on Wheels, but we're also really supportive of shared meals, lunch clubs, and support with shopping. And while that focuses primarily on making sure that people can access food, we also try and build in thinking about how support for people around food, such as Meals on Wheels service, can also benefit the wider good food economy by providing good food jobs. Many Meals on Wheels providers pay at least the real living wage, etc., as well as some who are really trying to procure local and more sustainable food where possible. And importantly, today's event is supported by the Churchill Fellowship and the Rank Foundation, who supported me in a number of ways as a Churchill Fellow, pursuing looking at support for people, particularly Meals on Wheels and enterprising approaches to delivering Meals on Wheels support, but also have supported me to do this focus bit of work around hospital discharge and beyond. Because to me, it seemed like a really good point in people's lives and services lives to support people and provide those kind of services. So just a bit of housekeeping. We are recording the webinar and we'll share the slides afterwards and the recording. The guide that we're launching today, we've not put it in the chat yet. We'll put it in the chat at the end of the session. Just want you to be focused on the webinar and not reading the PDF on the side. There are lots of us here today, and it's fantastic to see people introducing themselves in the chat. Please introduce yourselves, say where you're from, what organisation you are, your interest in this topic, share any information and links. If you want to change your name so that people know who you are, you can click on the three dots in the top of your window on Zoom and change your name if you want to. We are trying to use the Q&A button to gather Q&A questions for the Q&A session rather than in the chat. So if it's possible, please click on Q&A at the bottom of your screen rather than chat to ask any questions as they come up. We'll let all the presenters speak and then have a panel session with covering as many questions as we can at the end. Don't worry too much if you find the Q&A difficult or you put something in the chat. My colleague Raki is kindly converting any questions from the chat into the Q&A so we can manage that. So without further ado, I'll share some screens and just go through the agenda. So I hope you can all see that. This is the front cover of the guide that we published today, which, as I said, will be available after this meeting. Excuse me. And our agenda today is I'm going to talk briefly, I hope, not for those 15 minutes I allocated myself a bit greedily, just to go through the guide and the project itself and mention some of the other projects who aren't speaking today. And then we've got three fantastic places and projects represented by our four speakers. We've got Brenda Black, the Chief Executive of Edinburgh Community Food, Corrina, O'Flaherty, Seddon, and Lucy Peyton from Cambridgeshire and Peterborough from their two respective organisations, and Vicky from UK, Blackburn with Darwen. So just three quite different areas, I think, in terms of location and context, but we hope that was a really interesting mix of speakers to talk about their work around this agenda. So just to say a little bit about the Home from Hospital project, we used the project over the last 6 to 9 months or so to collect some examples of good practice from around the country, bring those together in this guide we're publishing today, and hopefully send some clear messages to decision makers, particularly at the local level, but I think potentially there's future work at the national level to really emphasise the importance of the kind of services and support we're championing today. And just a message from Dame Prue Leith, who's a sustained patron and has kindly submitted a forward for the guide. Her quote there: "If patients are not to find themselves back in hospital, they do need to eat well and build up their lasting strength. Besides, isn't food one of the great and lasting pleasures of life?" And I think Dame Prue's forward to the guide presents a really powerful call to action, a celebration of what's available, but also a call to make sure services are supported properly, whichever kind of organisation is delivering them. So the guide's only 20 pages or so, and it's not sort of too dense in terms of text, but we've got Dame Prue's forward, a bit of an introduction to the issues, and I'm very conscious that I've dipped my toes into this area of work. Particularly health services are, very complex structures, and of course different across the 4 nations and regions within them. But we focus in the report on 5 key elements that seem to have come through the surveying, through the conversations I've had about how to make this kind of support for people work when they are discharged from hospital. Got a number of case studies, which I'll talk about in a little bit more in a moment, and some suggested questions in there to help explore people's needs. I think many services have these locally and are much more skilled than I at asking people the right questions, but we sort of pooled some of the questions from across the different projects to give people a bit of a start around that, as well as flagging very important tools and resources, including tools to screen for malnutrition, etc. So really great to be able to include those tools where a lot of work has been done, and there's no need to reinvent the wheel on those. So the 5 key elements that we found through our research around providing effective support is: number 1, developing a joined up approach to food and hospital discharge, putting in place a coordinated local plan and support to ensure people will have access to food when they're discharged from hospital. And of course that relates to beyond just food. People aren't single dimension, but our work as Sustain is obviously focusing on food, so that's why our guide particularly emphasizes that. Then number 2, understanding people's needs, which we know isn't always straightforward. It's not necessarily as simple as just asking people what they need and want. People aren't always good at expressing their own needs or in a position where they can. Family members and professionals might not have the full picture of what's really going on in someone's life before they came to hospital, but also how things might have changed in terms of them managing food and preparing meals once they return home. Then number 3, navigating local support options. So it's making sure that key people, whether that's individuals, their families, professionals, know about all the support that's available in an area and how to access it. And there's some quite powerful examples, I think, in the guide of hospitals and community services working together to talk to people before they are discharged from hospital, to really understand what is available and how people can access that. And then developing and communicating the plan that's been put in place so that the key people who are involved in supporting somebody, as well as the individual themselves, know how it's going to work. And perhaps that might be for a short-term period before something more permanent is put in place, or someone's needs have been fully understood. And then, number 5, supporting local providers, really ensuring that those services that are available or could be made available in local areas are properly resourced, and that importantly referrals come through to them, but to increase their reach, but also make sure that they're viable. It can be very challenging, I think, to run services that are only reaching a limited number of people. There is an economy of scale, but obviously in areas with more dispersed communities, such as rural areas, size isn't always everything or possible. So I just quickly want to highlight some of the other case studies in the report. So this slide is kind of breaking all the PowerPoint rules of being far too busy with too much text, too many photos, but I consciously did that to try and give a sense of, just in the guide, how much how much the range of services there are, their geographical spread, and really celebrate that. And these are just the ones that, you know, I happen to chance upon through this relatively short period of time. So I know there's much more out there. And I just wanted to highlight those those projects and services that aren't speaking today. So we've got Meals on Wheels services in Bristol and Hertfordshire that are really linking in well to hospital discharge teams and support, and particularly in Hertfordshire, linking in with the community navigators to make sure people are accessing meals where that's appropriate, as well as the other support they provide. We've got the food chain working across different parts of Scotland, helping people with their shopping and actually helping them unpack it, put it in the fridge, and as well as providing sort of a bit of conversation, companionship and other support. We've got staple food items being delivered to people in Bury in Lancashire, and provide Devon and the British Red Cross are working together to provide food packages in Devon as well. And then in Dorset, the Can Wellbeing Collaborative is joining up support across Dorset to really ensure people are accessing all kinds of support, including food. So without further ado, we're going to move to our speakers. So Brenda Black from Edinburgh, if you could unmute yourself and turn your video on, we'll move to you for your slides.
Thanks, Simon. Okay, we good? Yep. Okay, let's go. Thank you so much for giving me the opportunity to get to talk today. Just to say very briefly, we are at the very start of this journey. I am by no means an expert in this field, and we're learning as we go along. It's been great that Simon's managed to pull together so many people from across the UK to help with this journey. I've already met lots of people within these talks. I've met Jill and our team from Aberdeen and Moray. I know that Tilly's on the call. These things all feed into all the work that Sustain does across the UK and helps to bring collaborators together and create a community. And also it helps us to feed into the Good Food Nation bill with this work as well. My connection with this sort of stems from, working in the hospitals as a dietitian. And when I started with Edinburgh Community Food just before COVID, I got some of my colleagues in the hospital to build what they would see as a sort of discharge box for people out in the community. So that was the starting point, but unfortunately that had to get shelved for 2 years. There was a wee thing called COVID that sort of came into play. But it's great to know that we're not alone in tackling this. So we have our community partners in the NHS, we have our community partners across the city, and we also have the community that Sustain has provided here. And I wanted to talk about community collaboration from hospital to home comforts. And the reason why I've called it care and not crisis is because community work doesn't just come at the point of crisis. We want to come at the point of care and building care plans. If you could move on to the next slide, Simon, thank you. Community led approaches really work. And we know that we really work because we've been working in 25 years tackling health inequalities through our community work. And as you can see there, we have our values, which have been voted by our members, our staff, and our partners across the city. We do healthy food work with all different age groups in the community. We have a sustainable agenda. Our core funding, importantly, comes from health and social care, and we have a very definite remit and a quality assurance to meet across the health and social care. If you want to change to the next slide, Simon, that would be great. Thank you. These are the dignity in practice principles that we use in all the work that we do. These were principles that were set up by Nourish and the POOF, the Poverty Truth Commission community, with people that have lived experience, volunteers and community food initiatives across the UK, across Scotland, and these have been in practice for about 7 years, and we use these in everything that we do around food. So we people need to be involved in the decision making, making people with direct experience help to shape the care around food, recognise the social value of food, so the ability of food to keep people well, to keep them connected, to keep them part of society, to provide opportunities to contribute, about have their say on the food that they receive, when they receive it, and the quality of food, and leave people with the power to choose. So making sure that people have choices in their life around food. And I'm sure that everybody will agree that when someone has a significant health incident in their life, when these things, that something is, you know, monumental as that happens to them, food can fall down the agenda, and food services and the connection of services can fall down the agenda. And we know that it's how we show love and care for people. So it's really important that we keep these principles in mind when we do any good food work, and that we make sure that food and the dignity around it is promoted at all times. If you could move on to the next slide, Simon, please. So hospital to home comforts. Number one thing to remember is that everybody matters. The top line ensures people get back to their home and the community environment as soon as it's appropriate. This is a vision that came from the Vision Healthcare Scotland, part of their consultation with people across Scotland. And this translates into the 6 themes of the Health and Social Care Partnership in Edinburgh. And when I started to write about how this all comes together and how these funds all come together and how this all happens, I actually get really bored with the slides. So I thought, I'm not even going to try and explain that. I'm only going to try and explain what the themes are around everything that we do. So they want to see, for our sort of core funding and what we do in terms of tackling health inequality, they want to see us work with shared purpose, build relationships, all the things around community mobilisation and everything that's listed there. And I'm not going to read through them, but what I would say about this is that we need a shift in the foundations in terms of influence and change, which is not easy. We need to co-create joint processes for the whole system to move forward. Collaboration in action to solve these complex problems of helping people to live independently in community with the best nutrition that we can provide needs collective working. Community organisations like myself want to shape the agenda. We want to have a redistribution of power. It's not enough to ask us for case studies or lived experience, as important as they are. But what we really want to be doing is be part of the decision-making process. We want to be involved in the start and the solution generation, because we know from a community point of view that we are experts in this field in terms of community communication, and that we can readdress the balance of health and social care and the medical model and the balance of power. If you'd like to move on, please, Simon. So why is this important? Now, in terms of the agenda across the Lothians and across Edinburgh, I'll explain how it's important to us from that point of view. These numbers represent Scotland, and the reporting of these numbers is done by board. And the top number there, you know, if you look at, there's £142 million spent in delayed discharges, which goes down to £262 per day. And you think about the health and social care, the Edinburgh Integrated Joint Board Fund across the health authority is 4 million. So it's only a tiny fraction of this money that myself and community partners use to deliver the work that we deliver across Edinburgh. You can see there, £262 per day it costs for delayed discharge. And it also says that delayed discharges are only measured at the 3 days process. So we don't even know what it costs, you know, the sort of numbers for 1 and 2 days discharge, because we only sort of have the days from 3 days onward. We only record from 3 days onward. And when I spoke to, there's still a lot of issues around the reporting of these figures because they've just changed the categories, the coding and the broad context of the figures. I'm sure that Tilly, that is probably on the call just now, can talk more about the sort of delayed discharge beds occupied by older people and the particular risks of the older people in our community. 63% delayed discharge in terms of the older people. And this can have a real impact in their life expectancy. Do I want to say anything more? I think that what I want to say here is that small amounts of money in the community can make big impacts. If we get a small part of the budget that's spent on these things, we can make big impacts and we can relieve the stress on our NHS partners. If you could change your slide, please, Simon. Thank you. If you can see there that Glasgow and the Lothians, which includes Edinburgh, big cities have the big numbers, which is understandable. But if you can see there from the graph that Lothians has a particular issue, we're the top across the local authorities. And I think that's why, in terms of the priorities that are set out by the Integrated Joint Board in Edinburgh, it's one of the big asks when they're talking to us about our core funding, which is up for renewal. And we have been, they're looking to us to provide some sort of game plan and solution for this. And we are very able and capable of doing that. In terms of talking to allied health professionals who are frontline, we have had some consultations with them to work together. It's under, you know, from our conversations, they have no idea what we do or what we can do. And it's about us creating these opportunities to tell them what we can do. What they want from the whole system is they want people to go home when they're ready to go home. They want to maintain the flow. So they want people that have come in with a particular issue for it to be sorted out and for them to go home and then for other people to come in. If they don't go home, there's a higher risk of disease, there's a higher risk of failed discharge, which means that people go out and then they're readmitted very quickly, further decompensation, so long-term effects to their health and boarding. So somebody who maybe can't be discharged, that doesn't really have anything on, could be on a critical ward, so hogging a bed that somebody in a critical condition or needs surgery could possibly use. If you'd like to move on, please, Simon. So when we look at the 5 key elements from the hospital to the home to hospital report that Simon spoke about at the beginning, when we look at these and we look at what community can do, it's very clear. The first thing is to recognise that the Public Health Scotland, this is their phrase at the top of the page, this is what they're looking for and what they're supporting. And if you look at, as I've listed here, community, we are already there, we're already active, we're already providing this help for people. We're working with partners across the city, we do that all the time. We are very flexible, we're agile, we're resilient, and we're willing. People come to us, people phone us, families reach out to us, community partners reach out to us, and we know how to help with this. And we think that we have got a part to play in this hospital to home comfort as a priority to help people live more independently for longer. And we know that people deserve to have good food at every stage of their life. If you'd like to move on, please. So why can Edinburgh Community Food provide this? There's a list of our, almost our CV in this. And if I just go down to the solutions led. So in the solutions led, in terms of the meal provision, we do cooked meals in terms of our community partners. We do everything, the sort of meals in a bag for everybody in the household. We do recipes, we provide equipment, we provide welfare, befriending, volunteers. So we provide everything, and we provide it at an accredited level. In terms of logistical management, we provide 500 themed boxes every school holiday programme across the city for 500 homes in terms of the school referral system, Discover. So we have a logistical understanding of this. All we need is the chance. And I've put a wee thing in there, is we're mindful of dependency and legacy. So it's not about keeping people tied to organisations for longer than they need to be, but it's providing a holding hand to get back on their feet with the right nutrition at the right time to help them to go back to normal living in the community and enjoying their life. And that's all I have for you today. So thank you so much for listening. And, you know, let's talk a wee bit more about care and not just community in a crisis situation. Thank you.
Thank you so much, Brenda. That was really great to hear the sort of general importance of this work, but also what you're doing in Edinburgh specifically. So now I'm going to introduce you both, if that's okay, so that I'm not interrupting your presentation halfway through. But we're going down to Cambridgeshire and Peterborough to hear from Corrina O'Flaherty Seddon, who will then be followed by Lucy Peyton. So Corrina, if you can unmute yourself and turn on your video, you should be spotlighted.
That's great. Thanks, Simon. So yes, we're delighted to be part of this project and to be featured in the guide and what is just such an important issue at the moment. So Simon, if you could flick on to the first slide, please. Thanks. So Care Network has been working with people in Cambridgeshire for over 35 years, helping them to access the emotional and practical support they need when they need it most. And we do this through our Help at Home, Community Navigator, Community Development and Wellbeing services. Next slide. So this includes that working with people to help them when they're leaving hospital to make sure that they have access to good food that will help them to build their physical strength and boost their well-being. Also, you know, ultimately reducing the likelihood of readmission to hospital and just helping them to get back on track. Next slide, thanks. So our Help at Home service has coordinators based in each of the local hospitals here in Cambridgeshire and Peterborough. And they work closely with discharge planning teams to support people whilst they're still on the ward to get kind of plans in place for them to return home safely. So our person-centered, strength-based approach means that we can work with people to really understand their individual circumstances and help them to join the dots as they're leaving hospital. So we can do this through our Help at Home service, but also through our Community Navigator and Wellbeing services, which can help people to access that ongoing support. And we do this in collaboration with our local statutory and voluntary sector partners. And the type of support that we can offer might be some shopping, some light housework, making sure that things are ready for the return home. They've got a, you know, the home is warm, there's food in the fridge, things have been cleared from what might have been quite a quick kind of exit to leave to hospital in an emergency. So we can get that all in place, and we can work with the patient to help them to access longer term support for things like, you know, shopping and local community groups, time banks, all sorts of things to help people kind of get back on track and remain in contact with their community. Next slide. Oh, sorry, back one. Thank you. And just, yeah, it's really important just to say that we don't do this in isolation. We work very closely with our local partners, and you know, that's to help us to extend our combined reach and avoid the duplication of effort. We also work to kind of simplify the client experience, because often when people are accessing our services, you know, they may be feeling very overwhelmed, at a low ebb, unable to take in a lot of information coming from various different sources at that time. So we try to simplify that and try and kind of join the dots for people and help them to navigate through the service and through the system. So we have lots of local partners, including Age UK. Lucy's coming up next to tell you a little bit more about their local work. The case study that you'll see in the guide that we chose involved working with Age UK to provide the particular client ongoing support for them to stay safe and well at home. And that's ultimately our aim. So thank you very much for having us to talk today. I've given my contact details here. I know we have a Q&A at the end, but if anybody would like to reach out to discuss anything more, please do get in touch. Find me on LinkedIn. And please do get in touch with via social media as well and help us to reach more people. Thank you very much. Bye. And over to you, Lucy.
Hi there, everybody. I reiterate the same, thank you for being part of this, because it is very important, very paramount at the moment. So my name is Lucy Peyton, Chief Operating Officer at Age UK Cambridgeshire and Peterborough. We have, over the last 3 or 4 months, really got strong together with the voluntary services, the health services and adult social care through a piece of work called it's the Nesta 100-Day Challenge. And that really has strengthened the need of all the voluntary services and charities putting together, making it's very accessible to have that support around the county. Okay, if you'd like to just move on to the next slide, please. So the particular service I want to talk about is obviously hospital discharge and admission avoidance service. So this is something that we've been doing for several years through local authority pots of money of winter pressures. Through COVID, we were awarded grant and funding from NHS England, and it wasn't just over winter. Obviously, COVID came along, so this has been all year round. It is not a seasonal thing, it is all year round. And the focus on earlier discharge home is making the support services needed more. So with this service, I just want to sort of give you a brief overview that we can support in different levels of a discharge. So that could be while they're still in hospital. So it's a pre-discharge intervention, key safe fitting, moving a bed downstairs, anything to make that journey home quicker. The day of discharge, that's getting them home and seeing that they've got everything they need. Those already at home who maybe have been recently discharged, or those that are living at home but have been identified perhaps by the local district nurse or social prescriber or someone that needs support at home to prevent an admission or a readmission. So this particular service is initially gives support up to 4 weeks, but obviously we don't leave anyone stranded. There's longer term services available where the need is identified. So with our 9 core services across Age UK Cambridgeshire, we support practically, emotionally and socially. If you'd like to go on to the next slide, it is a bit more food specific. So accessing food, I've just put some key words just to sort of try and give a overview of how we can help with accessing food. So on the actual day of discharge, this could be, some hospitals do give packages of lunch in a bag type thing. Sometimes it doesn't happen, so we're just there to make sure that there is access to food on that discharge. So it could be shopping on behalf of the patient, obviously them choosing their own food and their own preferences. Our staff have health and safety food safety certificates, so they can prepare a light meal, warm something up in the microwave, etc., and then get them a few essentials to make sure they've got what they need over those first initial days. Personal choice, that's what we want to, is person-centered support we give, so they choose their own brands. We can meet their dietary needs, any cultural or religious factors, and their own allergies. Every patient that is discharged home, or anyone that is referred through to this service, there will be a home visit, and that is fundamental to assess and have a real picture of their living conditions, and it does help identify to make sure they have all the appropriate things, for example microwaves, a working fridge, maybe they've been in hospital for 5 or 6 weeks and they've got out-of-date food. So let's have a look at all the health and safety implications, making sure it's clean, and then look at some aids to help them support their independent cooking going forward. For access to funds, because we quite often see either they're struggling to access their own money, or maybe they are struggling actually financially. So we can either go out and buy it for them, invoice them, and let them pay, you know, a month's time to give them time to settle home, or help them apply for grants, food banks, vouchers. We have a discretionary fund for those severely having hardships, and we can carry out benefit checks and things to maximise and increase their income going forward. So then, like I say, we don't leave anyone stranded, so we will look at their future arrangements and explore their options that they have, whether that's shopping locally, so they've got that inclusion still in the community. We have quite a few sort of like local co-ops that will accept a phone call and cash on the doorstep, or obviously there's online shopping with local supermarkets. We deal closely with having hot meals delivered, so I'll just put some examples on my slide there. Meals on Wheels, Wiltshire Farm Foods, Milk and More. And it's really just important keeping up with all the local projects that are set up, you know, keep popping up in the county. I'll give an example there, Diamond Hampers, who are an organisation, charity in Huntington, and that have nearing end of life food, so it's a lot more cheaper and more accessible, etc. And we can also look for local day centres and clubs that offer that companionship, but along with a nice hot meal. Assisted shopping is a service that we can offer, obviously to encourage their own mobility and empower their independence, and give them back their choice and control of what shopping and where they shop, etc. With our 4 weeks of support and ongoing, quite often past that date, having that regular contact and phone calls and home visits, it's very important, because, you know, we can keep that reminder of how important keeping them, you know, keeping their nutrition and eating well-balanced diets and regularly, and keeping hydrated. It's that constant reminder. It's often what the conversations consist of in the day, but that's good opportunity to do that. So moving on to the last slide, because I know we've only got 5 minutes and I'm trying to tell you so much in such a short time, but the slide there will show you the contact details to make a referral direct to this particular service, plus our information helpline that's open 7 days a week, and our website and Facebook. So going on to the last slide, we do tap into the NHS Better Health lunch recipes. There's quite some good things there. And I have put a link in that we did some work with Living Sport to create some easy recipes that were actually provided to us by our service users. So it's all there. If you want to know any more, then please do contact me direct on my email given there. Thank you very much.
Thank you so much, Corrina and Lucy. There was so much in there. It's really dense, but just to, I think, to be reminded about taking a strengths-based approach that is still asking people what they can do and enabling their independence as much as possible, and then the choice within that around food choices, preferences, cultural and religious needs, etc. I think it's really powerful, the work about going in advance to people's homes to prepare them so that that day, that return home is just that bit easier, and that the fridge is sufficiently full of good food that's ready to eat. And I think really nice to see the logic of thinking about the different stages when people are in hospital, about to leave hospital, have returned home from hospital, or may have already returned but have not been, needs haven't been fully met perhaps as part of that return home. And then I'm grateful, Lucy, to you for mentioning the sort of financial support that links into your work as well, especially as the cost of living increases for people. We do know that people will need their incomes maximised as much as possible, so thank you for that. Now turn to our last speaker, Vicky Shepherd, Chief Executive of Age UK Blackburn with Darwen. Go ahead, Vicky.
Thanks, Simon. Good afternoon, everybody. Always difficult going last, isn't it? So I'm hoping I'm not going to repeat too much of what's been said previously. But thanks for the opportunity to talk about our Blackburn with Darwen pathway. For those of you who don't know, Blackburn with Darwen is a unitary authority in the centre of Lancashire in the northwest of England. And although this has got our logo on, Age UK Blackburn with Darwen, I'm hoping that what I'm going to really be able to describe to you is the kind of partnership pathway that we've looked at developing over the last couple of years, really, in terms of supporting people not only with nutrition and hydration, but on a broader basis. If you could go to the first slide, please, Simon. So the way that hospital discharge works in our area is that people are supported through the discharge process, either by the Age UK Take Home and Settle service, and for us that's actually provided by a neighbouring Age UK Lancashire, because we share a hospital footprint, and they mainly support people on pathways 0 and 1, and we also have the local authority led Home First team, which is mainly people on pathways 1 and 2. So depending on the complexity and level of need would depend on which service supported those people actually home from hospital, but those services both have a common kind of function around assessing and considering access to food and nutrition as part of the discharge support process. So in those kind of first 72 hours of somebody being at home and reorientating themselves, having come out of hospital and having been fed for 3 times a day for however long they've been in there, and what does that look like for them now living independently back at home. And that either is arranged or provided directly as part of that initial short-term support package. That will be very much dependent on the individual circumstances. So as part of the assessment, it would look at whether there's any family support, what previous arrangements were in place that could be resumed, or it might be that there's a new additional need. The previous speakers have talked about things like making sure the fridge is stocked up. We call it the bread and milk offer here, making sure the fridge is clean, along with basic things like people can get in, they've got their keys, the heating's on, etc. So that the stuff that's already been described really by the previous speakers is delivered as part of the support through those initial discharge pathways. If you could go to the next slide, please, Simon. But looking forward for that person around maintaining independence and avoiding readmission, one of the things that we've got in place is that we take referrals into our Age UK Here to Help integrated care service at the point of discharge. So we would work alongside whichever discharge support service is operating for that person to pick them up with consent. And the Here to Help integrated service offer provides a kind of holistic wraparound support to complement any ongoing clinical and care that's needed. So what I would say is that the Here to Help service that we provide isn't only for people on the hospital discharge pathway. Our staff work also as part of the community integrated neighbourhood teams. So we do have that offer for people who've been at home but might have a different need, or perhaps their health condition is deteriorating. But obviously for the purpose of today, I'm focusing on the discharge pathway. So the Here to Help service offers a comprehensive guided conversation, taking a strength-based approach with the person and any family that they choose to have involved. And that focuses on a whole range of issues around quality of life, health and well-being, and supporting that person to maintain independence and be as resilient as possible. And that includes particular conversations around nutrition and hydration, and also associated issues, things like access to dental care. You'd be surprised how many people are wearing ill-fitting dentures and therefore can't eat a healthy, well-balanced meal. So taking into account some of those other things that might be affecting their ability to have a good diet. And we call it a conversation on purpose rather than an assessment, because we really do want it to be a conversation with that individual about their choices, likes, dislikes, needs, preferences, etc. So the structure is really conversational. as far as possible, that takes place in the person's home, so we can see their environment that they're living in, and talk to them about any potential opportunities to improve the equipment that they've got available, etc. And the conversation would cover everything from shopping to preparing and cooking food, what's their appetite like, access to balanced diet, fluid intake and weight management concerns. Our staff are all trained in nutrition, malnutrition and hydration issues to kind of pick up any particular concerns and identify when an onward referral might be beneficial for more specialist input. And then the short and longer term solutions are explored, goals put in place with the person to look at supporting the maintenance of their independence, not creating dependence on services particularly, and as much as possible supporting health and well-being. And the solutions are, as have been described previously, really very much tailored to the individual, but could include things like shopping delivery services, and that might be from local supermarkets, or in some areas of the borough there are voluntary services that offer that kind of delivery service. Delivery of Wiltshire meals already been mentioned today, but also things like looking at provision of aids for the safe food preparation and cooking, with the aim of, wherever possible, re-enabling people to do that for themselves. Or it might be about accessing some community-based support through lunch or other food clubs in the community, information on healthy eating. And alongside all of that, as part of that guided conversation, we also do the kind of income maximisation work with people, so benefit checks and support to make sure that they are getting everything they're entitled to, and therefore as much as possible can afford to buy good quality food and have that balanced diet. And we also look at things like digital access and digital skills. So if people did want to do their own online shopping and want to learn how to do that, we can offer that option through our kind of digital inclusion project. So we really try to embed access to food and nutrition within our kind of whole holistic approach, working with a person. And very much tailoring that to the individual. I think that's the theme that's gone through the three presentations, that this must be about what that person really wants and needs. And just to finish off, if you want to just go to the final slide, Simon. I haven't given you my contact details. I'm happy to put them in the chat, but I thought I'd finish with this picture, which I think, whilst clearly buns and cakes aren't necessarily great from a nutritional point of view, this is a picture of one of our service users who's been baking. And I think the look on her face really demonstrates for me the joy and positivity that access to good food can bring to people. So I thought I'd just leave it at that point. Thanks, Simon.
Thank you so much, Vicky. And I think, yeah, that is really great. I'm very conscious that we don't have a person who benefits from these kind of support and services speaking today, but I think for us to hold this image in mind and that joy that person is obviously having is really fantastic. And I think the point, providing bread and milk to people sounds like such a simple thing, but I think so many people assume that's covered by somebody. So I think the fact that you've emphasised quite a lot, I think, Vicky, from the previous speakers, it's these key messages really do need to get heard, because I've also heard some pretty harrowing stories in other meetings and through my survey of situations where people have been left without for a number of days, and that's obviously really worrying. And the links you make to denture support, malnutrition, hydration support, digital support, and having those conversations with people again, rather than sort of perhaps slightly tough assessment processes that don't feel so person-centered, is great. So I'm going to stop sharing the screen, even though I really don't want to take that picture off, and we'll get all the panelists up. If you can just turn on your cameras and unmute yourselves, panelists, but don't all speak at once. We've got a question comes through that actually, yes, I'm not sure that you may have mentioned it, some of the speakers, but it'd be great if you could just quickly say how your work is funded. for your community and voluntary sector work. Sort of what are the funding models? Is it grants? Is it income generation? Is it people paying contributions, etc.? Lucy's got her hand up, so we'll go with Lucy and then Corrina, then the other two.
Yeah, I mean, obviously it's a struggle. It always is to fund these sort of things. I know I did mention that we were funded through NHS England. That has now stopped. So the money at the moment is through winter pressures, which is local sort of NHS, CCG and local authority monies. But it is something that needs to be addressed, and I think it's a big focus, across the whole of the UK to address longer term, rather than just, it's not over winter, it's not over a few months, it's ongoing. So but yeah, it's normally from the local authority or NHS.
Thank you, Lucy. Corrina, did you want to add?
It's just very similarly to Lucy there. Yes, all of our services are free to the end user, and depending on the project or service, funded slightly differently, but typically Community Navigator contract is commissioned by Cambridgeshire County Council. We also have funding for health for a health user service and transport projects supported by annual lottery. So yeah, it depends.
Thank you, Corrina. I just had a bit of interference there. I could understand broadly what you were saying. I don't know if it was me or you, but perhaps type in the chat just in case what you just said. If that's all right. Sorry about that. You were fine before, but Brenda, did you want to add?
Yeah, I guess it's a whole menu of funding. We have put in for a community commissioning process for money to do the collaboration, because in order to do anything like this, you need to have set up your pilot of collaboration, and that needs seed funding, so the people that are being referred at the moment, we're picking them up through an emergency food fund across the city, but we need the money for the pilot.
Thanks, Brenda. And Vicky, anything you'd like to say about funding more generally? But there's also a question specifically for you about dealing with different local authority boundaries and CCG, Clinical Commission Group, health boundaries with funding and commissioning allocations. The person's from Bath and North East Somerset and thinks they might have a similar situation to you with boundaries.
Okay, so our Here to Help service is funded as part of a broader health and wellbeing contract that we have commissioned through the local authority in Blackburn with Darwen. So that's part of an ongoing commission that we tendered for a couple of years ago and was successful in winning. The discharge services that I referred to are funded through the NHS through discharge funding. So the take home and settle and the Home First offer. I guess the capacity of those fluctuates depending on what winter resilience monies are available at particular times of the year. So there is some flux in the volume and capacity. And I guess the solutions that I described, so those community solutions, would usually be very much funded by small pots of grants. So that might be a community lunch club or something like that. So a mixed model, I suppose, of funding, and not without its challenges. In terms of CCG boundaries, so Blackburn with Darwen currently has a local authority and a CCG with the same boundaries, so that they're both working in Blackburn with Darwen, but I'm sure in common with everybody else, as the NHS restructure takes place, we're part of a what's called a Pennine place-based partnership, so more NHS commissioning being done on a larger footprint, hence our partnership with our neighbouring Age UK. So I described that we don't deliver the actual take home and settle bit, because it wouldn't make sense for two Age UKs to be working out of the same hospital. So we've worked hard to make that collaborative model where they actually do that practical take home and settle the first kind of 24, 48 hours and then pass them on to us for the longer term. So I think the only solution to those kind of boundary issues is collaboration and working across boundaries with organisations, but that isn't without its own challenges.
Don't know what you mean, Vicky. Thanks very much. And I'm just going to combine these last two questions just because of time. So if the panelists could just pick whichever bit they'd like to respond to, or both. So Michelle's asking, are you being given MAST malnutrition screening results for patients as they're discharged, or being asked to do those at any point during your time with people? And a further question about coordination. Historically, there has been a lack of coordination when older people have been released from hospital. Have things got better, I suppose, is what the person's asking, and where are, I guess, opportunities for that to be better. So maybe if I just come to you, Brenda, first, and then I'll go around.
In terms of the MAST and discharge, no, it's not. It's, from our point of view, it's only things that are within our scope of practice at the moment. We're not involved in that clinical part. So we don't have that collaboration with the clinical partners for that part of it. What we do have is organisations and people in the community health aspect, or sheltered housing, getting in touch with us and asking us, our family members getting in touch with us and asking us to provide some care, some nutritional care when people are being discharged, or shopping care when people are being discharged. So no, we don't have those. It would be great to have an exit from hospital MAST screening to be passed on, but I think quite a few of the people would not register on the MAST necessarily, but still need nutritional and support when they go back to their home. So I guess that's what I would say about that.
Thanks. Corrina?
Yeah, we don't have access to that data, that nutritional results that we always ask about.
Sorry, your mic's, it's not just me, is it?
No.
Sorry, Corrina, do you mind typing in the chat? Because we don't want to lose what you're saying. You might. Oh dear, I'll just Lucy, please.
Yeah, I mean, I know that Corrina at Care Network and I, we work very similar basis. So I'm hoping I'll answer the same what you were trying to say. Information sharing is a big issue. So we don't have that information passed on to us. We have got honorary contracts with the hospitals, which and we're all working really closely to try and do some better sharing of data and what we need to know. That is a big piece of work that is quite top of the priority at the moment for all involved. Each hospital's got their own system, and they don't talk to each other, and I know there's a big national thing about sharing care records, so that is a big piece of work happening this year.
Thanks, Lucy. And Vicky?
Just to be brief, because I'm conscious of time, I would say the MUST stuff is not consistent. So sometimes we do get that information, sometimes we don't. We can access it through our integrated neighbourhood team connections, but I think probably more work to do on being consistent around that. And just to pick up the other comment around lack of coordination, the other question, I think there has been, certainly in my experience, there's been a lot of work done to improve that coordination. That's not to say there aren't still some people who fall through the net, and quite often those people are people who perhaps felt that they could manage, and then when they've got home the reality hasn't been quite that. So I think there's something about us looking at different touch points with people as well.
Thanks very much, and thanks for all speaking concisely, because yes, we are at our close now. There has been a question about access for younger people, and I know some of the case studies in the guide, that support is available for younger people as well, but obviously some organisations like the Age UK's do have a specific remit to support older people, but I know that can be quite a large remit of people now. It's not just the oldest. So I think, yes, there's some information in the guide about some support that's available for older people, but younger people, sorry, but I think it is a mixture of provision out there, so that is a very important question. So I did want to just bring us to a close now, but I will share, as promised, the link to the today's guide that we published in the chat. I've just shared that, but I will email it, everyone that's attended today and all those who registered, with a link to the publication, a recording of today's presentations, the slides, as soon as I can get this recording up onto YouTube, which can sometimes take a while at this time of day, but I'll try and send that out definitely by the end of tomorrow. So thank you very much to Brenda, Lucy, Corrina and Vicky for taking the time to join us. It's really wonderful to have so many people from around the country and perhaps beyond joining us, and thanks so much for the time you've all taken to prepare for today and answer questions so thoughtfully and share your contact details as well. So we'll end it there. Thanks very much everybody, and I'll be in touch.
Thank you.
Thank you.
Thank you.
Thanks. Bye bye.